Hi everyone, my name is Rachel Victor and I'll be presenting today about celiac disease. So the patient that I was assessing was a 32-year-old female. She is about 5 feet 5 inches, which is 165.1 centimeters, and she weighs 113 pounds, which is 51.4 kilograms. She is a runner, so while this is still a healthy weight, it is on the lower end, but since she works out so much, it makes sense that she is on the lower end of the healthy BMI. And after conducting a 24-hour recall with her and discussing with her how much she knows about celiac disease, I came up with two nutrition diagnoses. The first one being impaired nutrient utilization, and the second being limited food and nutrition related knowledge. So while I was discussing with her about what she does and doesn't know about celiac disease and any of her lifestyle factors, I was informed that she was diagnosed with celiac disease about 3 months ago, which was on August 22nd, 2021. For about a month, she completely avoided gluten-containing items to the best of her knowledge, and found that her symptoms subsided for about a month. But after that, she reports symptoms of abdominal pain, gas, bloating, and fatigue for about 2 months now. And she didn't meet with a registered dietitian after her diagnosis. So she was only given this vague pamphlet to learn from, and even tells me herself that she didn't read through the whole thing, and just really tried to do it on her own because she thought she knew a lot about gluten. But it was clear after conducting my 24-hour recall that she did not know much about it, and that's why her symptoms have been coming back. So celiac disease can present itself in several different ways, but the most classic ways that it presents itself is through chronic diarrhea, abdominal pain, cramping, bloating, and gas production. Along with that, some other symptoms that aren't GI related include bone and joint pain, muscle cramping, fatigue, peripheral neuropathy, seizures, skin rashes, and mouth ulcerations. And a lot of the times people go in for IBS or other like gastrointestinal issues, and they don't realize that they have celiac until they're screened for these types of diseases. So a lot of times people will go in if they're anemic with iron deficiency. They think they have thyroid disease or IBS, but it can also be a complication of any one of those. So the primary organ that celiac disease affects is the small intestine. When the small intestine are exposed to gluten, there is a toxic and inflammatory response, including the T lymphocytes producing cytokines that cause the main inflammation, and activated toxic T cells do some pretty good damage to the enterocytes. And as a result of this, the villi that line the small intestine can be pretty poorly flattened and damaged. When the height is decreased in the villi, the absorptive ability of those villi is reduced severely, and they're flattened, which causes a reduced absorptive surface area and loss of digestive enzymes. This can cause malabsorption, which can cause rapid weight loss, iron deficiency anemia, and other malabsorption issues. And celiac disease is often accompanied with other autoimmune diseases such as type 1 diabetes, thyroid disease, primary biliary cirrhosis, and rheumatoid arthritis. And like I was saying, with the microvilli being so severely flattened and the absorptive ability being inhibited, that does make them at a much higher risk for being nutrient deficient, as their body's not able to absorb the nutrients no matter how much they're consuming. Okay. So for diagnosing celiac disease, it can be done in two ways. The first way being the traditional diagnosis, which is still considered the gold standard because it's the most accurate. It includes basically just a biopsy of the small intestine mucosa, just looking for any atrophy to the villi, any cyst hyperplasia, or any lymphocytic and plasma infiltrate in the lamina propria. And any of these being documented will be proven 100% if the symptoms following a gluten-free diet subside, just to see how the intestines can respond to the absence of gluten. And then with serological testing, it's commonly used to diagnose celiac as well. It uses tissue transglutamase and anti-endomysial IgA antibodies, because those are present in those who have celiac disease. So TTG is the most commonly used biomarker with a 95 to 98% sensitivity and a 94 to 95% specificity, while EMA has an 85 to 98% sensitivity and a 97 to 100% specificity. So the nutrition therapy for celiac disease first begins with a nutrition assessment. And this clients are examined for any anthropometric changes and nutrient imbalances. Like I said, celiac can present itself in several different ways. So those are the two main criteria. Excuse me. Also with the nutrition assessment, it's important that the client's social networks, knowledge and beliefs, and adherence to behaviors are assessed, because gluten or celiac disease, it can be a really difficult disease to manage, as it requires very conscious decisions every day about the foods that you eat. So it's important that these clients are supported and they know a lot about what it means to adopt a gluten-free diet. Following the assessment is a nutrition diagnosis that has three main categories, including the impaired nutrient utilization, altered GI function, and food and nutrition related knowledge deficit. Along with the diagnosis follows the nutrition intervention, which is a lifelong intervention. Gluten must be avoided at any way, shape, or form. It can't be in the foods that you eat. It can't be in makeup, lotions. It basically just can't be in or on your body at all, which can be really difficult. And I believe in this philosophy that within nutrition, that it's more important that clients can be told what foods they can add rather than just only being told what they have to avoid. Obviously, with celiac disease, gluten avoidance is the main priority, but it's also important that they are told foods that they can still include that are maybe similar to those that can contain gluten, such as like whole grains, quinoa, brown rice, whole grains that can provide some of the same nutritional benefits and are kind of similar in their long chain polysaccharide, all those benefits that they give. So along with avoiding gluten, it's important that clients still optimize the nutritional quality of their food items. Food items that are made gluten-free, so they're processed to not have the gluten anymore, are often processed so much that they lose a lot of the vitamins and minerals that were in there once before, and they're not fortified with them because they're not required to at this time. So it's important that they are still keeping track of their vitamin and mineral intakes to make sure that they aren't becoming deficient in any of those. Upon the initial diagnosis of celiac disease, it may be required that the client avoids lactose as their villi are still being restored, and it may be difficult for them to digest dairy products. So as long as they allow their stomach, their small intestine to heal back to their normal state, they can slowly reintroduce dairy back into their diet. And in 2012, the FDA passed a law requiring companies to, or food production companies to label items as gluten-free only, and they can only do that if they contain less than 20 parts per million of prolammin. And there are also some resources for managing celiac disease, including the Celiac Disease Foundation, the Canadian Celiac Foundation, and the Gluten Intolerance Group of North America. So the prognosis for celiac disease includes villus height to be restored as long as the client follows a gluten-free diet. With the restoration of the villi also comes the relief of the maldigestion and malabsorption, which provides a lot of gastrointestinal relief to the clients. So following a gluten-free diet should reduce those symptoms, but there are still some that struggle with refractory celiac disease, which is defined as persistent intestinal damage to the small intestine despite a gluten-free diet. The cause is mostly caused by unknown gluten contamination and other coexisting diseases. Cross-contamination is a large issue with celiac disease, especially in restaurants, because many of them don't have gluten-free fryers, and they will cook foods in the same pans that had gluten in them before, or toasters are a big one too. So those are big cross-contamination hazards. Eating out is one, definitely. And the coexisting diseases that also cause similar symptoms include like IBS and other, like maybe lactose intolerance that cause similar symptoms in celiac disease. And the main treatment that is available right now for celiac disease is just following a gluten-free diet. With following a gluten-free diet also includes avoiding cosmetic items that contain gluten. A lot of makeup has it, some lotions have it too. And right now, since that only is the avoidance of gluten is still the only available treatment right now, but they are investigating some therapies using different enzymes and vaccinations to hopefully reduce the amount of response the body has to gluten in those who have celiac disease. With that comes the emerging medical nutrition therapy research. So one method of reducing the symptoms associated with celiac disease is the pretreatment of whole gluten with bacterial-derived peptidases. So those would help in digesting the gluten before the small intestine react to it. And then there's also the blocking of the HLA-DQ2, which prevents the binding of immunogenic peptides, which cause those symptoms. Also the inhibition of transglutaminase 2, which is one of those main antibodies that causes the symptoms. Immune modulation, gluten tolerizing vaccines, and gluten sequestering polymers, and anti-cytokines that cause a lot of the inflammation associated with gluten are all being explored, and some of the research is really exciting to hear and listen about and research about, because some of them are already on the second and third phases of their development. So hopefully this can help people in the future. So now I'll discuss the case study that I conducted. My client is a 32-year-old female who's diagnosed with celiac disease about 3 months ago. Following her initial diagnosis, she very strictly followed a gluten-free diet and was pretty good about not having any symptoms with it. She is fairly new to having the disease and didn't really receive optimal education. She was only given like a vague pamphlet that she even said she didn't read through entirely herself. She kind of just tried to figure things out herself. And after talking to her and completing my a dime chart note, I came up with a nutrition diagnosis of limited food and nutrition related knowledge. So the first part of the chart note was the assessment, where I asked her age and any physical data that she had and any symptoms that she was experiencing. So she has chronic abdominal pain and diarrhea and fatigue, and has been feeling super tired lately, which goes along with the fatigue, which was something that I definitely noted, because she has just struggled with iron deficiency anemia before and has just been diagnosed with celiac disease. She lives with her husband and 2 children in a non-gluten-free household, so cross-contamination is definitely something that I was asking questions about. And uh, through her most recent labs, it has been found that she has low hematocrit, low hemoglobin, and low ferritin. So she is iron deficient. She is iron deficient anemic. She doesn't take any medications that affect her. She didn't take any medications at all. So nothing, there's no drug and nutrient interactions going on in there. She has had the same appetite, pretty much. Reduced appetite isn't a thing with that she has experienced. She also has a dairy allergy, so she avoids dairy as well. And from her current weight, I estimated her nutrient needs to those following right here. And when I was speaking to her, I took a lot of notes on what she does on a daily basis. Of course, I noted appetite. I asked her about her symptoms, still persisting with the abdominal pain, bloating, and diarrhea for 5 weeks now, and has experienced chronic fatigue for about 8 weeks. And since she was diagnosed with celiac 3 months ago, like I said, she was only offered a very vague pamphlet on foods to avoid and not really about nutrition therapy. So her proper nutrition education definitely was not there. The first thing I did was conducted a 24-hour recall. And from what she told me, I found that there could be maybe some possible instances of some gluten cross-contamination, and she was consuming one food item that did have gluten in it that she was unaware of. So with 1 cup of oatmeal, oats can sometimes be contaminated with gluten. They're oftentimes grown next to each other or processed in the same factory. So it's important that those with celiac disease who eat oats purchase ones that are made only in gluten-free factories. And for lunch, she did have a little bit of soy sauce, which she was unaware that has gluten in it. And then she had a gluten-free English muffin, which is a good way to be gluten-free, but she used a toaster that the rest of her family uses, which they use regular bread containing wheat to toast all the time. So that's another source of cross-contamination. And also the lunch that she had stored in her fridge was stored with containers that also have stored items containing gluten in the past. So that's another source of cross-contamination. And then for dinner, she ate out at a local food truck, and she didn't have any gluten containing items, but she did say she didn't ask if the food truck had a separate fryer for gluten, which I assume they do not because it's a smaller area. So definitely the restaurant and food trucks especially are a great source of cross-contamination for many food items. So that could have been a source of her reactions to gluten as well. There hasn't been any fat loss or any significant muscle wasting either. So her weight is fine, but she definitely has those symptoms of celiac still. And like I said, I spoke to an RN on my while doing my chart, and it's found that she had frequent watery stools since admittance, which is a really common symptom of celiac disease. And the first nutrition diagnosis I created was an active nutrition diagnosis with impaired nutrient utilization related to celiac disease, as evidenced by persistent fatigue, diarrhea, abdominal pain, and bloating following only a partially gluten-free diet. Since I did note that there were some items that contain gluten, such as a soy sauce in her just one day of her 24-hour recall, I believe there may be other sources as well. So her diet is not entirely gluten-free, and that's why I created that diagnosis. Another diagnosis that I constructed was a limited food and nutrition knowledge limited food and nutrition related knowledge related to improper education for managing celiac disease, as evidenced by unknowingly consuming foods that contain gluten, which is the soy sauce that she ate, and unknowingly consuming foods that are at risk for cross-contamination. She was not aware that they have to have gluten-free fryers, or that you can't use the same Tupperware as foods that have contained gluten in them, because cross-contamination is a big factor in that. And like I said, the small amount of gluten can still cause a lot of GI distress. So the main priority in my intervention is to educate my client on what a gluten-free diet is and how to follow it, because it seems like she's still kind of figuring things out and could use some more guidance with that. And the main priority from the main goal for the education is to implement a gluten-free diet. And I would do that through SMART goals, such as going to certain educational seminars, or buying new Tupperware on this date for that factor of contributing to celiac disease, which is a cross-contamination. Following that is monitoring and evaluation. I'll monitor any nutrient-related labs, such as her iron levels, her bowel movements. I'll definitely ask about that, and any other GI distress symptoms, and I'll reassess her in about a month. So along with this came with the makeup part of the case study, which is where my client received peripheral parental nutrition support, because they struggled with and they suffered from ileus, which caused them to need parental nutrition support. So my diagnosis for that was inadequate oral intake related to ileus complications as a physiologic metabolic etiology, as evidenced by a loss of appetite, bloating, constipation, and cramps. Using the standard peripheral parental nutrition standard of just a 4.25 ppm premix solution, I found it to be inadequate for her needs, as it had too much fluid and it would be too much for her body to take at once. It needs to be of a different formula, or CPN must be implemented. And my calculations are as follows: that shows that the osmolarity was too high and there is too much fluid involved. And then the central parental nutrition was implemented after my client did not show any symptoms or any signs of progress following 2 weeks on peripheral parental nutrition. So it's essential that they get the nutrients that they need in a more concentrated way to allow them to heal quicker and maintain their weight. So that would be then an active nutrition diagnosis, which is parental nutrition administration inadequate, with needs related to ileus, which is a physiologic metabolic etiology, as evidenced by persistent loss of appetite, abdominal pain, and constipation. From this, there was a much better formula for me to use, which was the 520 TPN, which is 5% amino acids and 20% dextrose. And my calculations are below. So with this formula at 60 milliliters per hour for 24 hours, it'll provide 1,440 milliliters of fluid, and that will be 1,787 calories, 72 grams of protein, and 288 grams of carbs, as well as 50 grams of fat in a piggyback 250 milliliter, 20% ILE at 25 milliliters per hour for 10 hours from the hours of 9 a.m. to 7 p.m. And the total volume provided will be 2,017 milliliters per day, including the premix solution and the lipid. So why was parental nutrition needed? It was needed because my client's GI tract was in too much distress to be able to digest and absorb food on her own. This parental nutrition provides nutritional support through formulas that are delivered through an IV, so intravenously. And it's needed when the client's digestive system is impaired to the point that it's unable to break down and absorb food on its own, which is obviously necessary for survival, but also it's really important for when you're healing from uh, any type of complication. Conditions that often require parental nutrition include parenteral nutrition include bowel obstruction, which is like, for example, the ileus that she's struggling with, a fistula, gastrointestinal surgery, malnutrition, and critically ill patients that are too weak to be able to digest food on their own. Also, those who may be at risk for aspiration. It's better to use parenteral nutrition because you don't want the risk of them choking on the fluids or on the tube itself. And it overall just allows the body to recover for those who are critically ill or too weak to be able to digest food on their own, or even just through a feeding tube. And this will allow, in the context of my patient, this will allow her ileus to recover through treatment and also through not being used in order to restore it back to its normal health, not to put any more stress on it. And that's all I have. Thank you so much.